This slide shows the central nervous system, and it's a very simple slide, but I like it because if you'll look at it, it kind of reinforces in your mind how important that brain and the spinal nerves are and how they're vital to the operation of the entire body. This is just a fun little slide. I love to tell therapists. In my former career, I was a director of nursing in long-term care facilities, and it was actually before we had therapy in buildings. And I will tell them that, you know, we did all these things. We did ambulation training. Our ambulation training was probably one person on each side of the patient or resident, and pulling them down the hall saying, move your feet, move your feet. So it's not really the same as what we see in therapy. But this slide is, the gentleman is getting ready to get up, and his tool to be able to get up is the dog is going to chase the cat and pull him upright. So I find that therapists find this kind of amusing. So I would say this is nursing's way of getting him up. This is Miss Bessie. Miss Bessie was our first cervical extension patient. And we've been dabbling with those designs for some time. We'd had the TLSO for quite a while, but the nurses at this facility, again, this was before you had therapists in buildings, the nurses had gone to a continuing education that we had done, and they immediately came up after it was over and told us about Miss Bessie. And she was one of their special residents. And she was scheduled for a feeding tube because you can see in her condition, they could not get enough food and fluids in her to sustain life. She was literally starving. They would not let her starve, but she was not taking in enough nutrition to maintain her life. So she was scheduled for a feeding tube, and they really did not want her to have that. They said they'd take away the last quality of life issue she has, because even though her food may not have appeared palliative to a lot of people, it was her food and she took it in by mouth. Miss Bessie was one of those people that they said they could lay her in bed with 3 pillows 24 hours a day and her head would never touch. She had a diagnosis on all her charting, her physician's notes, hospital notes, on her nursing notes there at the nursing home, that she had a fixed fetal position. Now think about the term fixed. This used to be used a lot. But we know now, unless you have an x-ray or some type of imaging that will see calcium in bone and see if there is a buildup of calcium enough around that bone that it prevents it from movement, from extending, then we don't have a fixed contracture. And it was interesting, I don't know how many years ago, but when Botox and baclofen and some of the antispasmodic drugs came out on the market, that all of a sudden these patients that were said to have fixed fetal or fixed contractures gained such range when these drugs were introduced to them. So they're miraculous drugs, and they can really be wonderful for somebody's quality of life. So the term fixed contracture, you just don't hear very much anymore, which is a very good thing, because these patients were kind of, I won't say written off, but the mindset was, again, going back to contracture management, was just trying to prevent them from having wounds and getting worse. People thought there wasn't anything you could do to make them better. So here we have Miss Bessie. Okay, and here the first slide on the left, again, as I said, it's our first cervical extension, slides down into the back of the TLSO, and this one was Lexan, and it had, see the fishing pole movement? It had that flex ability, but you couldn't heat mold it. Lexan plexiglass does not heat mold well, so it was just going to allow enough flexion to be comfortable for her, but literally log roll the patient on the back of this back brace, the TLSO. You would put it down, lay the patient back on it, put the front panel on, set them up, then put the shoulder straps on. Then if they require a cervical attachment, you just slide it down in the back and you put their forehead strap, and just ignore that strap going vertical. We had thought the forehead strap would slip off, but it didn't. But you can see in her neck the tone where she's pulling into that, continually pulling into that. So again, it's that fishing pole. Well, these nurses were so excited about the way she looked. They took us down the hall to see some more patients that had hands and feet and elbows and knees that had contractures. We came back less than 30 minutes from the time we got Miss Bessie up out of bed into her chair, and look on the right at the fixed fetal position, which would be curving over, right? She was totally relaxed. She was actually lounging back against the headpiece of that device. I could put my whole hand between the forehead strap and her forehead. We knew she was comfortable because they said when she was happy, she would sing hymns, and she was just singing away. Well, they were a pretty wonderful group of clinicians, and they really cared about Miss Bessie and all the other patients in their care. Every morning they would get her up, they would put her clothes on. You see here she had on a hospital gown because she stayed in bed all the time, because when they got her up in a wheelchair, she was so far forward. And if they put her in one of those reclining geriatric chairs, it just made her curl up into a ball even more. We don't like people recline. They need to either sit up straight, or let's get them to where they can sit up straight, and hopefully from there to stand. But Miss Bessie, they would get her up, put the device on, get her up in the chair, put the headpiece on, and they said they could set their watch for 15 minutes. At exactly 15 minutes, her tone would relax, her head would come up, and she would hold it up independently. Well, somebody got the idea one day. She wasn't touching the headpiece at all. They just took it out and left the TLSO on her. She held her her head up through breakfast, through lunch, and then she would go back, be put back to bed in the afternoon. So I'm proud to say Miss Bessie lived the last 6.5 months of her life with dignity, with comfort, eating her own food. No feeding tube, it was canceled. She held her head up, she could view her environment, she could maybe get back some stimulation, but just think how much more comfortable she was, and she was allowed to die with dignity in her own bed in that home that was her nursing home, with the people around her that loved her. Now let's think too about every time we prevent a feeding tube from having to be placed. You're talking about these people typically go to the hospital in an ambulance. They're transported that way on a stretcher. They go through maybe through the ER, but if they're admitted then and they have surgery, there's the surgical component for which these people are Medicare, they're charged. You'll have a surgeon, an assistant surgeon, you'll have the anesthesiologist, you'll have dressings, you'll have IVs, the anesthesia itself, and you'll have about 3 days in the hospital. Then you have the ambulance to transport them back to the nursing home. They may even go to a rehab facility, but they'll go to the nursing home then back on their Medicare Part A. So every time you can prevent one feeding tube or anything like that, a wound, an amputation, we take people off oxygen, because if you get them up and they can expand their lungs and hold their head up, many times they don't require oxygen therapy. So all these things are extremely expensive. They require more nursing care, or if they're home, they require a lot more of their family's time also. This gentleman had ALS, excuse me. That's Lou Gehrig's disease. Now he's completely alert and oriented, and he knows he has a death sentence. What ALS does is your muscles just forget how to work. So the weight of his upper body and head was more than the TLSO alone could support. And if you look at his facial expression in the third slide, it's devoid of any type of expression at all. Those muscles just aren't working, but he understands what's going on. But he was going to be doomed to a chair or bed because his center of gravity was so far forward, it would be dangerous for him to try to walk, or as we say, ambulate. So he was fit with the cervical extension for forward flexion, and they've started to mold it. They had a little more molding to do, but I appreciate the therapist that sent me these pictures. But the way it is, it held his head up to where, number one, he could see his environment and not his feet and the floor. It also allowed him, with a walker with rollers on it and someone to go beside him to make sure he didn't lose his balance, he could walk independently. That's huge for somebody like this that knows what's going on, to know that he can keep some type of independence for self-esteem, for his dignity, for comfort. If you sit in a chair all day long, you're miserable. The same thing with our patients. We need to keep them up and as active as possible for as long as possible. This is little Amanda, and she has cerebral palsy. Now, Amanda's school therapist is the one who sent me these pictures. And if you look at little Amanda, her posture probably actually started in the NICU. You see this very commonly with these type of patients. So we're going to talk about Amanda more in the next segment.